I'm very fortunate, though, in that there's been a number of very interesting talks this morning already defining, I think, why coagulopathy is important to try to understand, because of the way that one tries to modify it and change the outcome. However, in trying to define what is coagulopathy, I mean, it's essentially what are the multiple definitions of coagulopathy, I think. And most of what we'll be talking about today is acquired coagulopathy in various pathological situations. But of course, there are congenital bleeding disorders, which are in themselves a form of coagulopathy. And of course, we may create an acquired coagulopathy by some of our drug treatments, again, particularly pertinent in cardiac surgery in this audience. So the clinical context is extremely important in the definition of coagulopathy, and coagulopathies are always a very dynamic situation. So this is something we follow and treat in the clinical situation, as you're well aware. Easy question, why does it matter? Well, of course, we're all worried about bleeding risk, particularly in surgery, but of course also there are multiple prognostic associations of coagulopathy, so therefore trying to define it and diagnose what we mean by coagulopathy can be very important in trying to decide on the outcome of that patient. And it therefore feeds very much into management strategies, not only about bleeding risk and transfusion, but as Andrew was pointing out earlier, that the treatment with tranexamic acid may have multiple other outcomes. I'm just showing this slide of the 2010 National Comparative Audit of FFP use, because I think it really puts into context why we do need to try and define coagulopathy well, because actually the National Comparative Audit, the audit asked the question as to why FFP had been given. And in this slide shows the answers for children, and you can see over 15%, 18% were given FFP simply for abnormal clotting, with no bleeding, no invasive procedure. For adults, it was about 12%, but for neonates, it was actually 42%. And I think that's particularly important for them because, again, the definition of coagulopathy, one has to bear in mind for neonates that the neonatal ranges, of course, are different. And so one hopes that this definition of coagulopathy was correct, but we can't be sure. And certainly trying to make some precision about our definitions is very important, given the impact it has on treatment. Whether or not they should have been treated for abnormal coagulation alone is again, a moot point, and the answer would probably be usually no. Just to go back to really basics here, normal haemostasis, as you know, is a state of equilibrium balanced by procoagulant proteins, anticoagulant factors, fibrinolysis, platelets, the endothelium. And disrupting that balance either way may lead you to more bleeding or thrombosis. Again, when you're thinking about coagulopathy, it's actually really important to go back to basics and actually how clotting works. The initial damage to the vessel wall may be trauma, or of course endothelial activation for other reasons, and leads to the exposure of tissue factor and collagen. So von Willebrand's factor is able to bind to that collagen. You get primary hemostasis with platelets binding to the von Willebrand's factor and the collagen, giving that initial platelet plug, and also the phospholipids surface that the rest of the secondary hemostasis can take place upon. So tissue factor triggering the production of factor 10A and generating thrombin in this massive positive feedback loop, so that you get a clot formed in the right place, leading to cross-linked fibrin and a nice stable fibrin platelet clot. After clot formation, as you know, thrombin actually changes from being a very important procoagulant protein by binding to thrombomodulin, activating the natural anticoagulant protein C, and fibrinolysis is also activated, generating plasmin, again, as Andrew was talking about this morning. Excess thrombin is neutralized by antithrombin. And that picture, I think, that, as you know, there are various aspects of this which will be abnormal in a coagulopathy, and also various aspects of this that we can measure when we're trying to measure coagulopathy with all of our tests. This slide shows you more about the generation of thrombin. Again, this is the sort of waterfall cascade of clotting factor and fibrin generation that we're all aware of over many years, but it still stands. The extrinsic pathway, where you've got the activation of the exposure of tissue factor binding to the 7A, leading to some factor 10A and some thrombin generation, which then, by this massive positive feedback loop, it ends up with much more thrombin and fibrin, which then becomes cross-linked. And this slide, I think, brings it all together, showing how central thrombin is here, both in generating fibrin, but also activating platelets and also the natural anticoagulant. So the whole, and this, of course, is a simplification, as you know. So to come on to the detail of coagulopathy and the pathogenesis, I was just going to focus mainly on two situations, DIC and trauma, although clearly there are multiple clinical situations where coagulopathy is seen, including liver disease and cardiac surgery. And we have multiple measures. The definition of coagulopathy is a very difficult one, and we have multiple ways of trying to define it. In the laboratory, both conventional tests, which are used in clinical practice, and specialised tests, which are used to help to define coagulopathy in more of the research and sort of intermediate areas. And of course, on top of that, the point of care tests are becoming more and more important, which we'll be hearing more about shortly. The laboratory tests, the conventional tests, which we're also familiar with, are centrally the PT and the APTT, which are showing the extrinsic and intrinsic pathways of clotting. And these are generally long if the clotting factors are less than 50%. I mean, that's a gross oversimplification, but once the clotting factors have got below that, you start to see a change. And in general, haemostasis from the point of view of clotting factors is adequate if you've got factors around 25 to 50%. As you know, most of the algorithms that we use in terms of defining coagulopathy for these tests are where the ratio of these tests to normal is greater than 1.5. And in some cases, that is clinically validated, as I will say, but not all. On top of that, there are specific assays, so factor assays, both procoagulant, anticoagulant, not so much of a clinical practice, other than if you're looking at an inherited bleeding disorder or investigating thrombosis, certainly not so much a sort of rapid surgical use. And then, of course, you can look at fibrinolysis, you can look at clotting activation by various other specific tests. But very important and increasingly important are the global assays. All of these other assays are either looking at chunks of the pathways or individual factors, but the global assays are what we'd really feel should give us a better handle on what's happening in vivo. So there's the thrombin generation tests. As I've shown you, thrombin, of course, is central to so many aspects of normal clotting. And then there's the point of care test, the global tests, the TEG and the ROTEM, which you're so familiar with. So just to move on a little bit to DIC then, as an example of one of the coagulopathies, one of the best, I think, longest investigated forms of coagulopathy, and it's a very severe, extreme form of coagulopathy associated with systemic activation of coagulation, generally because of obviously an underlying disorder, often sepsis, and it leads to an outcome, depending on the balance of haemostasis, to either bleeding or more thrombosis or a mixture. Extremely severe coagulopathy. And there's been enormous amount of work trying to define DIC, trying to define the best management of it, either on the thrombotic end or the bleeding end, and whether or not you treat if there's no bleeding. There are many tests that one can use to look at DIC, and a number of these have been associated with adverse clinical outcomes, so platelets less than 50 as a mortality risk factor. The global clotting times, there's a coagulation factor consumption, so these clotting factor times are long in general, although this doesn't reflect in vivo hemostasis well, but is used as a marker. And here, certainly, the ratio of greater than 1.5 times the midpoint of normal does predict excessive bleeding. The INR is often often used, and this is just a general point to make, that as you know, INR is actually developed for the standardised for the monitoring of warfarin, and is often used as a sort of analogous to the PT, and it is often used in DIC, although strictly one should be using the PT. Fibrinogen levels, interestingly, although we all sort of think about them with DIC, one has to be cautious when interpreting them, because fibrinogen is at such an acute phase reactant. So actually, one might expect them to be much higher, and you have to interpret in the clinical context what they mean. Fibrin-related markers showing consumption and fibrinolysis, however, are useful, D-dimers particularly. They're raised in DIC but are not specific, so they're part of the pattern of the coagulopathy of DIC, but not specific for it. The natural inhibitors of coagulation, the antithrombin levels, the protein C system, they're both disrupted in DIC, and again predict survival and are defective in severe sepsis. TEG, there's of course interest in TEG in DIC, but as yet less well validated, and possibly, certainly there's an enormous impetus to use TEG, I guess, in surgery, trauma, where time is such of an essence, and possibly in DIC there's less, I would have thought, less of a impetus to be pushing that, but clearly a lot of interest in that. There is, very importantly, I mean, I've shown you that there's all these markers, and one for any coagulopathy suggest you can measure all of these different markers. There are so many possibles, but things have got fairly sophisticated with DIC in that they've over the years developed a scoring system for a diagnosis of DIC based on the coagulopathy, and it's fairly simple based on the easily available laboratory tests. And either it can be diagnosing an overt DIC, in which you get a very clear number of positives out of this list of the platelet count, the D-dimers, the PT and the fibrinogen level, or you continue monitoring it if it's borderline to see which way it's going. And that's a feature of the dynamic aspect of the coagulopathy. And the importance of doing that is that you can make the diagnosis of DIC, then that points you in direction of the management, and there are guidelines, BCSH guidelines for the management. Clearly the underlying condition is most important, but they're very clear also that plasma and platelets should not be used just for coagulopathy alone. It's bleeding and high-risk bleeding situations. So I think DIC is a good example where clearly you can measure many things, but actually they've used a very simple set of criteria for a practical diagnosis of coagulopathy here. The second example I was going to cover is acute traumatic coagulopathy. And certainly Nikki is a major expert in the audience, so I have to be careful what I say, but as you know, enormous interest and rapid amount of information and studies, particularly coming out of the war situation, on acute traumatic coagulopathy. And this is described as a very rapidly developing coagulopathy post-severe trauma due to the combination of two things, the severe tissue trauma and systemic hypoperfusion. And if this coagulopathy is present on admission to hospital, then the patient has a poor prognosis in terms of mortality, multi-organ failure, hospital length of stay. And like DIC, a lot of work has been done to try and define what is the coagulopathy in this situation, what are the particular features, because clearly it's got a very different context from DIC, and it's not primarily consumptive, so that there's a clear distinction in terms of the etiology. Specifically, there seems to be a dysfibrinogenemia, hypofibrinogenemia, and a systemic anticoagulation, so there's a lot of activated protein C aspects to it. Platelets are not working well, there's endothelial activation, and hyperfibrinolysis seems to be an extremely important feature. So interestingly, if you look at the measure of the PT, the ratio of greater than 1.2 has been found to be a really significant predictor of adverse outcome. And of course, if you look at the PT in the context of DIC, you wouldn't be terribly interested. So this is showing where, depending on the type of coagulopathy, the type of test that you're looking at to interpret the meaning is going to give you a very different outcome. Because you'd be happy to do a lot of surgery probably with a PT ratio of greater than 1.2, but here this had a major better prediction of mortality, as I'll show you in the next slide. And certainly the PT, therefore, they're clearly looking for something, firstly, quicker than these conventional assays, which, as you know, take probably at least an hour to get the result on, and also something giving a much better global picture of what's going on, what is the real important coagulopathy here, if it's not the coagulation consumption. And so clearly TEG and ROTEM, there's a massive amount of work done on that, although still needs really further validation, as I'm sure Nikki will be able to probably going to give you more information maybe. This is just the slide from the study showing the association with that PT ratio of greater than 1.2 with mortality and prothrombin ratio. So even though it doesn't look terribly exciting, it's very important in that context of that type of coagulopathy. So the management points, I think, that are coming out, and it's well reviewed, I think I've given you the reference on the next slide, of all of this work on trauma are clearly hyperfibrinolysis as part of this coagulopathy is very important, and this has been shown, by treating that in the CRASH-2 study, as we know has, and heard this morning, has a major impact. There's been a great deal of interest in high plasma ratios to red cells, as I'm sure you're all aware, a lot of it coming out of the military situation. And however, a lot of the studies showing benefit were retrospective, so there was a survivor bias to those studies. Those that had time to get a lot of FFP in were the ones that were surviving longer, whereas those that just had the red cells and then died and weren't, you can imagine how this happens. So that is clear when you look at the studies that that's the case. And certainly there seems to be, although there's been a lot of pushing of use of 1-to-1 ratios of FFP to red cells to treat traumatic coagulopathy, actually that doesn't, and I apologize if I'm talking about what you're going to talk about, that doesn't actually seem to show the benefit that one might have expected, and there are adverse outcomes of giving massive volumes of plasma to some patients. And in fact, there's been a recent Canadian Massive Transfusion Consensus Conference, which now is suggesting more of starting on a foundation ratio of 6 red cells to 3 FFP. And I think probably a lot of the messages that they're talking about treating the whole patient, and again, the patient blood management aspects, I think really, rather than just sort of formulaic treatment with 1-to-1 FFP and red cells. And again, coming out of the hyperfibrinolysis, the fact that this form of coagulopathy has been shown to have hypodysfibrinogenemia as a large part of it, there's more of a move now to think of giving early fibrinogen replacement, either with cryo or fibrinogen concentrate, as part of treating this coagulopathy instead of so much FFP. So I think this is another therefore a good example of how I'm trying to understand the coagulopathy, complex though it is and imperfect though the understanding is leading to management changes. So a couple of other, I won't talk properly about cardiac surgery here, but liver disease is another obvious example of coagulopathy, really quite different. The liver, as you know, is the major synthesizer of nearly all the clotting factors. And so in liver disease, you tend to get decreased pro and anticoagulants. And so in some ways, rather than it being a sort of coagulopathy, it's actually rebalancing of, you've got decreased both aspects. And that's gross oversimplification. But in fact, you can get quite abnormal clotting tests without risk of bleeding, and certainly you can try and give FFP and improve the prothrombin time, but it may be very difficult to do that. And actually, the guidelines are often that you don't need to try and normalize the standard tests in liver disease. The PT is a poor predictor of bleeding in that situation. And again, there's the hope that TEG may give a better overview, because there's all sorts of complex aspects to that coagulopathy. Cardiac surgery, I'm not really going to say anything about because you all know all about it. But clearly, in many ways, I think one could say it must be one of the most complex coagulopathies to try and deal with. There's so many preoperative factors, all the comorbidities, elderly patients, renal, liver problems, and all the bypass effect and the major trauma. You know more about it than I do. I think the other thing that's important to consider clearly is this sort of induced coagulopathy of these patients as well, particularly with the novel anticoagulants, which you may not actually be measuring or able to measure on your standard tests. So just leave that one to rest there. So in summary, I hope I've fulfilled the remit to try and demonstrate really there are multiple definitions of coagulopathy. It's the whole clinical picture, the whole clinical patient and the whole clinical picture that is particularly important here in trying to decide what form of coagulopathy one may be dealing with, and clearly it may not be just one. And coagulopathy often is not clearly related to bleeding or need for transfusion. And I think there's much more of a move, despite our FFP National Comparative Audit, to try and make sure that we are only treating with blood products in a patient who really has a bleeding risk. And I think we have so many potential tests to use in the laboratory. For standard clinical practice, we've clearly got a fairly simple number which can be used, as they have done for DIC, to try and define risks and management strategies. But clearly, this is part of ongoing research and clinical research studies at the moment. So I rest my case there.
Questions. Could I just ask a quick question while people are thinking? Acquired von Willebrand's deficiency, which we occasionally see in aortic stenotic patients, but we see almost universally in patients on long-term mechanical support. And I just wonder if you had any comments about how to handle that, and whether multimers are useful and that kind of thing. These patients are very difficult to handle, these long-term LVAD patients, and because of the miniaturization of these devices and the gradual reduction in their cost, they're going to become much more prevalent. At the moment, they're only occurring in a few centres in the UK, widespread in Germany, but I tell you, within the next 10 years, they're going to be much more widespread here. Do you have any thoughts about how to manage acquired?
Well, what I'd say is my main thoughts are from the excellent talk that Andrew gave at the HACS meeting last November, and I know you may want to say more, but that really the use of DDAVP actually, it seems, should be considered and fairly worthwhile, was the take I had from your talk, actually.
I think that's right. I think it's one of the few situations when DDAVP is really useful in those patients. They are a problem, as you say, because the high molecular weight multimers are progressively knocked off and they do bleed constantly from all mucosal membranes. But that's the way to go, I think, with those.
Yes, and also from in the brain and in the GI tract.
I'm just a facilitator.
Oh, you're a facilitator, right.
Can I make one question? Yes. The aortic stenosis question. The aortic stenosis question. There's quite a few publications now saying that actually they're not bleeding more when they have their aortic valve replaced, despite having acquired von Willebrand's. I mean, yeah.
Hayes syndrome.
But that's slightly different. What they're saying is that this is not really fair on Helen.
No, please do.
What I think some publications are saying that they're not bleeding any more than any other cardiac surgery, and the reason for that probably is that when they go on to bypass, they suffer an endothelial injury, and it releases a lot of high molecular, or the high multimer von Willebrand factor into the circulation, and so when they come off bypass, actually they're fine.
They're sticky.
So it's not a problem in that circumstance. Whether the TAVIs are a problem, don't bleed a lot anyway, but they may have an ongoing problem in the TAVI.
Any other questions? Oh, sorry, you're doing the stuff. Thank you very much.
Helen, I thought that really nicely crystallised coagulopathy into different types, because we tend to treat everyone the same, I think, in cardiac surgery without really thinking about the etiology actually influencing your treatment. And I wonder what you thought about the traumatic type, where obviously tranexamic acid looks exciting if it's given very early and not if it's given late. Do you know of any indications to give, for example, fibrinogen very early in that situation that you wouldn't perhaps do in DIC or the other forms?
Well, I mean, I think that is the feeling I'm getting from looking at the literature is that because this hypodysfibrinogenemia seems to be a major feature, that rather than giving these large volumes of FFP, actually, for a start, it's more practical to give quick bolus of fibrinogen if you live in Europe and that's what you have. But that actually it may be more effective to try and get on the top of the coagulopathy that way. But again, it is characterised, that coagulopathy, though, is being characterised, that is a major feature of it. And I think that's what's interesting in looking at the work that's coming out, really trying to define these different groups. And I think cardiac surgery, I guess you've got so many aspects to it. I think that's, and the dynamic aspects to it, I think probably will make it very complicated. But yeah.